Hi, it's Chris Wallis here at the SUO 2023 meeting, and I'm pleased to be joined with Katie Murray from NYU, and we're talking today about nephron-sparing and upper tract disease. So this is a talk you gave in the plenary session we just walked out of, and I think one of the big questions many of us has is who are the right patients for this kind of a treatment paradigm?
Yeah, so I think, there's a new interest in upper tract disease, which is exciting, right? Because it is a rare tumor, but, the recommendation is really those patients who are low grade, i.e. low risk individuals, right? Small tumor sizes, not extremely multifocal, patients who can be managed, very endoscopically, I think are the best candidates for a chemoablation or any sort of actually ablative technique, whether that's a mechanical ablation with our lasers or with resectoscopes, however that gets done, or a chemoablation, right? But I think that getting a good biopsy, a good diagnosis that's confident, to really think that you're dealing with that low-grade disease. I do a urine cytology to make sure that I'm not missing a high grade, right? It doesn't give me a diagnosis, but if the urine cytology is negative, and my biopsy shows low grade, gives me more confidence that I'm dealing with a low-risk individual.
Yeah, absolutely. That makes a lot of sense. And so I guess one of the questions that sort of naturally flows from that is, do we have a size criteria? Do we, I just saw a patient with like a 4.5 centimeter, UPJ tumor. Those are very hard to debulk endoscopically. Maybe a couple of settings you could get through it. Do we have size criteria, or do we just think it's, any real cutoff to guide that decision making within those low-grade patients?
Sure. So, in the clinical trial for, chemoablation with mitomycin hydrogel technology, it was less than 1.5 centimeters, where tumors had to be ablated down to that size. Now size in and of itself is a complicated thing of determining, how big something is in the upper urinary tract. But, in the trial, like I said, less than 1.5 centimeters, so that would be kind of the approval rating. That being said, there is some evidence, coming out in some more real-world data of how people are utilizing this, because there are patients with low-grade disease that have more bulky tumors, and for one reason or another you just can't afford to lose that kidney and you really want to spare it, and so that could look like a couple of ablations, mechanical ablations like with a laser followed by a chemotherapeutic, or even some discussions of sandwich type therapy. Now I don't have any good data or a way to tell you which way the sandwich should go, right? But can you downsize tumors with a chemoablative technique that makes them more surgically, laser ablatable? Or should it go the reverse? Should you ablate them down as much as you can, give them some chemo, and then take them back thereafter for that residual? I think it's a very interesting concept. I'm personally really interested in the idea of partial responders to chemoablatives for these bigger, bulkier tumors, or for these multifocal tumors, right? Somebody who you look up there and it's just like, oh, I can never ablate all of this, but could you downsize that and make them endoscopically manageable? So I think that partial response is a cool concept.
Absolutely, and I think that maybe leads into one of the questions. In bladder, we think of these topical therapies as adjuvant, right? We want to maximally resect, save for maybe some late-breaking data we saw today. But the notion in upper tract here is a little bit different with chemoablation. So how do you see the surgical and or mechanical ablation, as it were, and the chemoablation fitting together? Do we want to try and maximally resect and then add as more of an adjuvant approach, or are we intentionally leaving disease behind that we plan to treat with our chemoablation?
Yeah, so I think that's an excellent question. The first thing that I always say is that, we're surgeons, and there's very few things that come out that are actually going to take surgery away from us, right? We're all extremely busy. There's plenty of TURBTs to go around and ureteroscopies to go around. And so I don't think there's this fear that this chemoablation is going to take over for the surgery. Based on the way that I was trained and, this real idea, to me, it's really hard to say that I'm not going to try to maximally resect or get everything that I can visibly see with my, gross naked eye out. because that's what we've been taught. But I do think that, there's data out there for chemoablation, and there are patients that you can't go and maximally resect, right? Patients on anticoagulants, patients, for one reason or another, it's just not ideal. And so I do think it is a little bit of a paradigm shift, and we really have to start thinking about adjuvant versus, primary treatment. And that's hard in our minds as urologists.
Absolutely. And so, for the people who are convinced and are buying into this, nephron-sparing ablation approach, the follow-up is, how do we watch these patients? So EAU guidelines are probably the ones that I think give us the most guidance, and really we see there, a repeat ureteroscopy needs to happen pretty fast, and some axial imaging. But if we're doing chemoablation and we don't think we've got it, it's not just a surveillance imaging approach, how do you follow these patients going forward?
Yeah, so as you noted, there's no great evidence in what we're doing. We're worried about upper tract recurrences, you're worried about progression, you're also worried about bladder recurrences, right? And so there's multiple different things that you're thinking of. But if you are truly treating a low-grade patient, and you've done a chemoablative to the upper urinary tract, I alternate ureteroscopy with axial imaging. Could I miss small low-grade tumors with axial imaging? Of course I can, but I can get them the next time I take them to ureteroscopy. So instead of doing a ureteroscopy every 3 or 4 months, right, 3 or 4 operations in a year, I'll do it, every 6 months for the first year, alternating that with a CT scan. If you don't have recurrence after, in that early time frame, then I will stretch that out.
Absolutely. Well, thank you so much for your time. Really, fast-moving space in upper tract. Well, I guess all of urothelial cancer right now. Really appreciate you taking the time to join us today.
Sure.